All right. And with that, it is officially that time. It is 8:30 a.m. Central Standard Time. So we got to get started with our webinar. I'm excited. Now, as you can see, today we're going to be covering something called fluid frenzy, electrolyte essentials and beyond. And actually, what we're really going to focus on today are the two biggest electrolytes that are most likely to show up on the NCLEX: potassium and sodium. Those are the two big ones. You especially have to know those. So we're going to focus on that. Now, before we get started, and hello, good morning, I just want to quick introduce myself and go through a couple housekeeping rules. So first of all, my name is Elizabeth Diger. I'm a women's health nurse practitioner. I actually spent about a decade working in OBGYN. But prior to that, I was really a critical care nurse. I worked in ICUs, emergency departments, step down units, kind of all over the place. And you absolutely have to know your electrolytes well when you work in those areas. Now, of course, now I'm a teacher with Archer Review. I've been here for about going on 3 years now, and absolutely love it. I do webinars, live lectures, the live review. I help run the intense prep and live case study programs. I do private and small group tutoring, just a little bit of everything. So again, I'm very excited to teach to you guys today. Just a couple of reminders, just like you guys are doing. If you want to answer a question or communicate with me, go ahead and pop that right in the chat, just like you guys are. I'm going to be asking you some random questions. Put those answers in the chat. But if you have a question that you need answered, don't worry. We have the wonderful Jennifer Bonner on. She's one of our lead tutors. She is excellent. So if you have a question, put that in the Q&A and she can help. But just remember, there's only one of Jennifer. There's only one of me. It might take us a couple minutes to respond. So just try to be patient if you can. Okay, now we are going to be using a Slido poll today. You can join by scanning the QR code in the lower left-hand corner there, or you can just go to slido.com and use the code hashtag, or no, AR Electrolytes. AR Electrolytes is the code. But to start, I just want to know, where are you joining from? You can answer in Slido, or you could answer in the Zoom chat. Or if you're on Facebook or YouTube, feel free to answer there as well. Nigeria, New York, Long Island, Philippines, Staten Island, New Jersey, Israel, nice, Philippines again, Canada, I love it, San Diego, Thailand, all over the US, Ontario, Canada, good morning. A lot of people from Canada. Very cool. I think this is one of the coolest things about Archer Review. You know, we don't just teach students in one small area, not just in the United States. We get to teach students from all over the world. And it's really cool to be able to say that. It's really nice to be able to teach all of you. England, wow. Let's see, there was another one, Nepal, Chile. Excellent. Well, thank you so much for joining, guys, wherever you're coming from. And good morning or good afternoon or good evening, because I know you are joining from all different time zones. So just welcome. Okay. Now, the next question I need to ask is just, how are you currently feeling about fluid and electrolytes? This is a hard topic. And I always remember when I was studying this, I kind of felt like it was a little boring, to be honest, right? And a little bit confusing. I agree. But let me tell you guys, this is foundational. If you don't understand fluid and electrolytes well, it's going to be really, really hard to pass the NCLEX, because you need to have that foundational knowledge in order to really understand the body systems, the specialties, all of those other areas. So I'm glad you're here, because this is really important stuff. But yeah, these are usually the answers I get. It's confusing, it's hard. There's always something new to learn. But don't worry. Again, we're going to focus on those two most common electrolytes, sodium and potassium. Those are the big ones that are most likely to show up on your test. So let's go ahead and get started. Now, real quick, someone just said, hey, it's hard to remember the lab values. Guess what? Now they're going to give you the normal lab values, which is really nice. So don't worry about memorizing those, but you do need to understand what they mean. All right. So to start, we're going to talk about sodium. This is probably one of the most important electrolytes, in my opinion, because sodium does a lot for us. So first of all, sodium is the most abundant extracellular cation. Well, what does all of that mean? Well, if it's extracellular, that means that it likes to live outside of the cells. So that's the first thing. It mostly lives outside of the cells. It's a cation, and Shayna, you knew what this meant. That means it has a positive charge. And tell me, guys, in the chat, do cations like to join with other cations, or do they like to join with anions? Do they like to join with negatively charged? Yes. Anions, exactly. And I'm going to jump right down here. So chloride imbalances usually coincide with sodium because sodium is a cation. It has a positive charge. Chloride is an anion. It has a negative charge. So they like to bind together. And what molecule is this? NaCl. What molecule does that create? Good. Salt. Exactly. Yeah. So sodium and chloride like to go together. Positively charged cations like to join with those anions. So that's an important concept for you to know. Now, the reason sodium is so important in our body is it regulates water. If you guys recall, water likes to follow sodium. So if you have high levels of sodium in the body, you're probably going to have a lot of extra fluid retention, and that could potentially cause some problems. Now, sodium is especially important with one organ of the body, the brain, that nervous system. So the first thing I want you to remember about that is it doesn't matter if sodium is high or low, it's going to affect the brain. There's going to be changes to the level of consciousness. There's going to be changes to the way they think. So that's important to understand. But sodium also plays a role with nerves and muscle cells as well. And you'll see how that affects the client when they have high or low sodium. So someone just asked, what about the heart? Which electrolyte mostly affects the heart, guys? Which electrolyte? Potassium. So we're going to get to that one before the end of today's lecture. Okay, so I have my first question Slido here. What do you guys think can cause hyponatremia? What can cause that sodium to go low? Remember, the normal values for sodium are 135 to 145. So what can cause that to go low? Vomiting. Fluid overload is a big one that can dilute the sodium. That's a really good one. Yeah, hyperkalemia, burns potentially. That's more so going to affect potassium levels. Dehydration. Yep. Yeah, you guys got a lot of them. Ooh, SIADH. That's a good one. Diarrhea, sweating. Good. All right. Polydipsia. Yes. I'm seeing some very, very good answers. So let's dive into it. Let's look at what can cause hyponatremia. And of course, that's when the sodium level's less than 135. So really, you have to understand that fluid and sodium, they go together. So depending on what the fluid status is in your body, that can absolutely impact the sodium values. So, first of all, if there's euvolemic or hypervolemic hyponatremia, that basically means that the water level is so high that it's diluting the sodium that's left behind. So, let's start with euvolemic hyponatremia. Basically, the water in the body increases, but the sodium level stays the same. So if you look at this cup here, right here on the right, you can see that the water level increased just a little bit. The body is still euvolemic. It's not in hypervolemia, but because that water level increased a little bit, it's diluting the sodium. So it's decreasing the overall sodium levels in the body. And there's a lot of causes for this. Like you guys said, SIADH is a big one. And that's because, remember, that's syndrome of inappropriate antidiuretic hormone. Basically, there's too much antidiuretic hormone. That means the body is not getting rid of water. You're not peeing very much, and you're retaining water. You're retaining water, and that's diluting the sodium. Also, adrenal insufficiency and Addison's disease. With both of those, you're not going to have enough aldosterone. And remember, aldosterone helps you hold on to sodium. Polydipsia. You can have too much of a good thing. If you drink too much water, you can dilute your sodium. Excessive hypotonic IV fluids. That's something we might make a mistake about. And then just low dietary intake of sodium can cause this as well. Now, there's also hypervolemic hyponatremia, and that's when the water in the body really increases. It increases to the point of hypervolemia. So if you look at this bucket on the right here, you can see, whoa, there's way too much water, and that is significantly diluting the sodium. So we tend to see really low sodium levels with these conditions. The things that are going to cause this are going to be organ failures like heart failure, kidney failure, liver failure. All of those are going to cause fluid volume overload, but also nephrotic syndrome. That's a big one. Remember, it causes fluid volume overload. It causes that generalized edema. And tell me in the chat, guys, what do we call generalized edema? What is the term for that? Good. Very good. Anasarca. Anasarca. I'm so impressed you guys got that. Excellent. And then, of course, you can actually become overwhelmed with water intake if you take in too much water. So, there have been cases where people have died simply from drinking too much water. Their sodium gets too low, they have a seizure, and they can actually die from that. So you can have too much of a good thing. But there's also hypovolemic hyponatremia. And as you can see, that's when both water and sodium are lost together. But in this case, a little bit more sodium is lost than water. So you just don't have enough sodium in the body. And you guys got a lot of these when I asked you that question, vomiting and diarrhea. A big one is NG tube suction. Very important to know, guys, if you have a client with an NG tube, do not let them eat anything. Don't let them drink anything, even ice chips. What's going to happen is that water's going to get sucked out of the NG tube and it's going to leach out sodium as well. So very important safety tip with those NG tubes. Diuretics, burns, like you guys said, and then excessive sweating as well. Now, what does someone actually look like when their sodium is low? Well, remind me, guys, what organ is the most impacted when sodium is either low or high? Yeah, the brain. So that's absolutely what we're going to look at first. That neurostatus is going to change. You might start out a little confused, then you get lethargic, you get stuporous. This can even lead to cerebral edema and increased intracranial pressure. It's dangerous. But the real worry when sodium is really low is seizures. We get real scared about that. Does anyone know what is the danger zone for sodium? What level, when it gets below that level, do seizures commonly happen? Nope, with an NG tube, no water, no ice chips. And exactly, Shayna, you're on a roll. Less than 125, if I can write 125, that's the danger zone. Now, remember, the other things that sodium does is it's going to regulate the nerves and muscles. So we're going to see some musculoskeletal changes. Weakness, shallow respiration, some deep tendon reflexes are going to be decreased, which is dangerous, muscle spasms, and even orthostatic hypotension. So if someone's sodium is low, not only would I put them on seizure precautions, I'd probably put them on some fall precautions. Additionally, they're going to have some hyperactive bowel sounds. That's going to cause abdominal cramping. And then they have some cardiovascular system changes. And really, the cardiovascular system assessment, it's going to help tell you what's causing it. So, for example, if you have a client who has weak pulses, they have hypotension, dizziness, that tells you they probably have hypovolemic hyponatremia. I would look for causes like vomiting, diarrhea, that sort of thing. On the other hand, if they have bounding pulses, high blood pressure, I'm looking for that hypervolemic hyponatremia. So again, that assessment can tell you a lot about the cause. Now I want to pause here real quick. We always get a lot of questions about these webinars. Hey, I'm thinking about using Archer. I don't know what package to use. It's confusing. There's a lot to choose from. Well, let me tell you about our number one package. This is the one that most people choose and have really good success with. It's called the SurePass Combo, and you get a lot of bang for your buck with this. You're going to get all of the on-demand videos. You're going to get an entire huge Q bank, but you're also going to get a one-time pass to the 3-day live review. Basically a rapid review. It's really good to take that if you're going to test soon because it reviews the concepts that are most likely to show up on the NCLEX. But something else that isn't listed here, you also get access to all of the live lectures every Tuesday and Thursday and all of the live case studies every Monday, Wednesday, and Friday. So you just get so much with this package. It's a really good value, something to consider. If you're interested, RN level students are going to scan that QR code, and PN level students are going to scan that QR code. All right, back to it. So low sodium, again, really concerning, especially for that nervous system status. We're worried about those seizures, so we've got to treat it. And how we treat it depends on the underlying cause, right? So if it's hypovolemic hyponatremia, we got to restore both water and sodium together because both are really low. And typically what we're going to do if it's mild is we're just going to use plain old 0.9% normal saline. That works in the vast majority of cases. But if it's really severe, it's severely low, we're worried about those seizures happening, we can use a hypertonic solution like a 3% normal saline. Now, again, the cause determines the treatment. So if it's hyper or euvolemic hyponatremia, there's too much water, right? The water is diluting the sodium. So we've got to restrict free water. No drinking gallons of water here. Just you got to measure out what you're going to give them and really watch that. And you've got to replace the sodium. So you're going to give sodium tablets potentially. And this is one of those rare times where you're actually going to encourage a high salt diet. We don't do that very often in healthcare, but we would do that here. And depending on the severity of the sodium, we could also give osmotic diuretics, which are basically diuretics that help to push, particles like sodium out. Actually, I'm sorry, they push water out, but they retain the particles. I misspoke. All right. So we got to get that water out. Now, in terms of a diet that's high in sodium, again, we don't encourage this very often. But if the sodium's low, this is one of the rare times we actually would encourage it. So, pretty much foods that are high in sodium are going to be heavily processed foods, basically. So, bacon, butter, canned foods, cheese, my favorite. I'm a Wisconsin girl at heart. Hot dogs, lunch meat, and of course, you can always just add table salt. And sometimes we can prescribe sodium tabs, but just remember anytime you're correcting sodium, please just carefully monitor that sodium or that neuro status, because remember, it's being impacted by the sodium levels. And that leads me to an important point here. When you're replacing sodium, you do have to do it very slowly. If you give it too fast, you could actually cause cerebral edema, increased intracranial pressure, and all of a sudden you're damaging your client's brain by accident. So we typically give this at about 0.5 milliequivalents per hour. Just nice and slow is the way to go. Now, we also have to talk about hypernatremia. And again, when sodium's high, it's really going to affect that nervous system again. So, what do you guys think? What can cause sodium to be high? Kind of the opposite problem here. And you can tell me in the chat too. Yeah, DI, diabetes insipidus. That's the opposite of SIADH. Good job. Dehydration. Yeah, a lack of fluids is going to make the sodium more concentrated. You guys are getting it. Good. Diet. Yep. Too much sodium in the diet, eating too many of those processed foods. Hypertonic fluids. Sometimes we are the ones who are causing the high sodium. That's not uncommon at all, that we're the ones causing the problem. All right. So let's look at those causes. So again, it depends on the fluid status as to what the underlying cause is. So first of all, with euvolemic hypernatremia, this is when the water just decreases a little bit. It's still euvolemic. It's still technically a normal volume for the body. But because that water decreases, as you can see, it's going to concentrate the sodium that's left behind. And we see this when you just naturally lose small amounts of water over time. Hyperventilation, excessive sweating, fever. You're actually losing water during those occasions. But you guys got a big one, that diabetes insipidus. Remember, with that, there's not enough ADH. And therefore, you're just peeing and peeing too much. And as you lose that water, it's going to concentrate the sodium. Now, you can also have hypervolemic hypernatremia, and this is when you have increased sodium and water, but in this case, you have more sodium. And a big one, like you guys said, is Cushing syndrome. That's going to cause hyperaldosteronism, and you're going to retain sodium in water. Also, again, a lot of the times we're the ones causing these problems. A hypertonic IV fluid for too long, sodium bicarb, we're correcting acidosis, and oops, we give too much sodium. Increased sodium intake. And again, if there's too many corticosteroids on board, that's going to increase aldosterone. And then there's hypovolemic hypernatremia. And this is when water and sodium go down together. But in this case, you lose more water than sodium. And a lot of these things are the same things that cause hypovolemic hyponatremia. It just depends on how well hydrated you were before these things happen. So again, dehydration, diarrhea, vomiting, burns, diuretics. And of course, if you keep someone NPO for too long, it can cause some issues with sodium balance as well. Now, again, when we look at the assessment, we got to look at the brain first. It's always going to affect that nervous system first. So, again, the client's going to have some level of consciousness changes. They might be, to start, a little restless and agitated, and then they become lethargic and drowsy. They become stuporous, and all of a sudden they're in a coma. So, this can get bad quickly, and you've got to recognize those early signs. Again, remember, sodium affects nerve and muscle functioning. So we're going to see some musculoskeletal symptoms, especially some kind of overactivity of the muscles like twitching and cramping, and it can cause some weakness as well. Now, I want to hop over here. These other symptoms, I always found those hard to remember. But the way I remember this is when you have high sodium, think of that client like someone who's trapped in a desert. So high sodium, think trapped in a desert. You're going to have flushed skin. You're going to have decreased urine output. You're going to have dry mouth. You're going to have a fever. Very, very similar symptoms. And of course, that cardiovascular system assessment, that's really going to decide what the underlying cause is. So again, if you have edema, bounding pulses, we've probably got hypervolemic hypernatremia. If we have hypotension and weak pulses, they're probably dehydrated, and we need to replace some fluids. And we do have a nice little mnemonic here, fried and salted, and that kind of spells out the assessment findings as well. Fever, restlessness and agitation, increased fluid retention and edema, and dry mouth again. That skin's going to be flushed. Definitely there's going to be that altered level of consciousness, low urine output and thirst, elevated blood pressure, and decreased energy. So that can help potentially. Now, in terms of treatment, again, it always depends on the underlying cause. It depends on what their fluid status looks like, and that's going to tell you how you need to treat things. So definitely, again, if we just have a little bit too little fluid, if we have that euvolemic hypernatremia, we just need to put that fluid back in the body. And typically, we're going to do that by just allowing them to drink as much free fluids as they want. Now, ideally, we're going to just have them have oral intake of fluids because remember, they're euvolemic. We don't necessarily want to give IV fluids because then we could over replace the fluids and cause other issues. So we're just basically going to have them drink water. With hypervolemic hypernatremia, well, we got to get rid of especially the sodium, but we probably got to get rid of some of that water as well. But remember, with this condition, we're usually kind of the problem causers. So we got to figure out what we're doing and stop it. Have we been giving too many hypertonic solutions? We got to knock that off. Have we been giving too much aldosterone or steroids? We got to stop that. But we're also going to give loop diuretics. What's a good example of a loop diuretic? Tell me in the chat. What's the big one? Yes. Furosemide. Exactly. Good old furosemide. And remember, you guys want to make sure you're studying the generic name for the NCLEX. But that's not only going to push water out of the body, it's going to get rid of that sodium as well. And then after we get rid of some of that excess water and sodium, we can then have them start drinking water again to dilute the rest of the sodium that's left behind. And finally, we have hypovolemic hypernatremia. And of course, we have to replace water in this case. And we're typically just going to, again, do that with an isotonic solution like normal saline, because compared to the high sodium in the body, it's relatively hypotonic. Over time, it is going to dilute that sodium. But again, monitor the neurostatus carefully the entire time you're correcting these, and correct these imbalances slowly so you don't accidentally cause cerebral edema. Okay, let's do a couple tricky Slido questions. Oops. Okay, so the nurse is assigned to care for a client with a sodium level of 122. Which assessment findings does the nurse anticipate based on this lab result? And do notice it is the select all that apply. What are you guys thinking? It's a hard one. All right, let's see what you guys were thinking and show the correct results. So, absolutely, if we have a sodium level of 122, that's dangerously low. We're getting into seizure territory there. So, absolutely, there's going to be some neuro changes, there's going to be some confusion. Remember, this causes the abdomen to cramp. So there's going to be some nausea and vomiting, but there's not going to be hypoactive bowel sounds. And there is also not going to be those tall peak T waves. Remember, we see that with potassium imbalances. All right, let's try another one. Okay, the nurse is caring for a client whose most recent serum sodium level was 152. Which of the following signs and symptoms does she suspect are caused by the client's sodium level? Select all that apply. Again, it's another hard one. Good. Yeah, you remembered my trick, I think. Very good job. Okay. Let's take another peek. Let's see what you guys are thinking. And you guys did great on this one. 88% of you got the two right answers. So, absolutely. Again, this is a very high sodium. So, again, it's going to impact the brain. There's going to be lethargy. And then remember, when sodium is high, think about someone trapped in a desert. There's going to be those dry mucous membranes, but it should not affect the respiratory system. There's not going to be tachypnea or hypoventilation, and it shouldn't impact circulation either. So I wouldn't suspect cyanosis. Okay. Now, we're going to get into potassium in just a minute, another really big electrolyte for the NCLEX. But again, I just want to tell you a little bit about the services that are offered at Archer. And one of my favorite is small group tutoring, honestly, because it's just such a good deal. You're not going to find a whole lot of other places that offer this kind of deal. Basically, for only $25, you get an hour with the tutor. Now, there's going to be other students as well, and it's going to be on a predetermined topic, but you can learn a lot for pretty cheap, actually. And as you can see, we have a lot of different wonderful small group tutors, all kind of different specialties amongst these tutors, but some examples of what you can learn: prioritization, how to answer those darn select all that apply questions, testing strategies, how to interpret EKGs. Pharmacology is a big one. You name it. We cover a variety of things in these small groups. So if you're struggling with something specifically, look and see if there's a small group on it, because you get a lot of bang for your buck with these. All right. But we got to get into potassium. Like I said, this is another really important electrolyte. Now, let's break it down. So, this is found mostly inside of the cells. It's the most abundant intracellular cation. So, it's a cation. Again, it's going to have a positive charge. So, very often, this likes to bind with chloride as well, just so you're aware. Now, when we're looking at the normal serum value, we're just looking at the potassium in the blood outside of the cells. So believe it or not, when we look at this value here, which is normally 3.5 to 5, that doesn't account for most of the potassium in the body. Most of that potassium is living inside of the cells. So that's an important concept. And it's somewhat similar to sodium. Remember, sodium impacts nerves and muscles. So does potassium. It impacts nerve impulse conduction, and it's especially important for muscle contraction, especially a very specific muscle, heart muscle contraction. So, like we were talking about before, sodium, always think brain first. Potassium, whether it's high or low, think about the heart first, is how you want to think of it. And then finally, do know that potassium is important in the acid-base balance. Basically, when your body becomes acidic, it causes potassium to leak out of the cells where most of the potassium lives, remember. So if you're in acidosis, that potassium is leaking out, it's going to cause high levels of potassium, which can be dangerous. So we got to start with hypokalemia. And of course, I have another Slido. What do you guys think can cause hypokalemia, that low potassium, less than 3.5? You can tell me in Slido or the chat. Very good. Medications. There are a couple. Yeah. Diarrhea, vomiting, malabsorption. I like that one a lot. Excellent. Diuretics is a big one. Good. GI problems. Burns are actually going to cause high potassium. We'll talk about that in a little bit. Low intake. Yeah, that was the other one I was really looking for. Very good job. So let's talk through it. Let's talk through the causes of hypokalemia, that low potassium. So just like you were saying, certain drugs are actually going to push potassium out of the body. Laxatives, especially a certain type of laxative. Does anyone know there's a special kind of laxative that really pushes potassium out of the body? Does anyone know? K-exolate actually is the big one. Diuretics, especially loop diuretics, corticosteroids, because remember, just like we see with Cushing syndrome, too many steroids is going to cause retention of sodium in water, but it's going to push potassium out of the body. Also, inadequate potassium intake. That could be people who are NPO, maybe just have a really bad diet, or maybe they have an eating disorder like anorexia or bulimia. But a big one they like to test on is alcoholism. And there's two reasons alcoholism is going to cause low potassium. First of all, when you're dealing with alcoholism, typically your diet is not good. You're prioritizing the alcohol and you're not taking in other healthy foods and drinks. But also, the secondary reason, alcohol inflames your GI tract. And if your GI tract is inflamed, you can't absorb things well, including potassium. So alcoholism is definitely a big one. Too much water, you can actually dilute the potassium. So again, polydipsia, we might be given too many IV fluids, could be causes. And then heavy fluid loss. So NG tube suction again, vomiting and diarrhea are going to be big ones, sweating and wound drainage as well. And there's a couple other ones, alkalosis. So remember what I said before, acidosis causes potassium to leak out of the cells and go up. Alkalosis causes the opposite. It causes potassium to stay trapped inside of the cells. And then too much insulin can actually cause low potassium as well. Does anyone know why? Tell me in the chat. This is a harder concept. It's tricky. So remember, yes, urine. Yes, exactly. You guys got it in the chat. I'm so proud. Basically, remember, insulin opens up the pathway into the cells. And what potassium likes to do is it likes to grab onto that sugar and it goes back into the cells with that sugar. So insulin drives potassium and sugar into the cells. Exactly. Good job. All right. So, when we think of the assessment, what you really have to remember again is that potassium affects nerves and muscles, especially one important muscle, the heart. So, always, whether potassium is low or high, we're always really thinking about the heart first. We're going to put them on a cardiac monitor and we're going to look for dysrhythmias. But we're also going to see a lot of muscle weakness, decreased reflexes, weakness and flaccidity, shallow respirations, because remember, there's an important muscle that helps you breathe, the diaphragm. Decreased bowel sounds and constipation because peristalsis slows down. That's going to lead to abdominal distension. There's going to be orthostatic hypotension. So consider fall risk with these clients. And there's also going to be a weak, thready pulse, which means that cardiac output is probably impacted. And we have the 6 L's of hypokalemia. Again, lethargy, low respirations, limp muscles, cramps, and there's also lots of urine output actually. Basically, when you have hypokalemia, when you have low levels of potassium in the blood, it can actually cause excessive urination as a side effect, just so you're aware. Okay. But remember, when potassium is low or high, you've got to think of the heart first. And pretty much the first thing you're going to do is you're going to put them on a cardiac monitor. You're going to get an EKG right away. Now, when potassium is low, the 2 main changes you're going to see on the EKG are that prominent U wave, see that right here, and that flat or shallow or inverted T wave, like you see right here, actually. Those are the 2 main changes with low potassium. That's what they're likely to test you on. But there's also going to be a slightly peaked T wave. Now, it doesn't matter if potassium is low or high, there's always going to be 2 standard changes to the EKG if potassium is out of range. Doesn't matter if it's low or high. There's going to be that prolonged PR interval. You can see that right here. And there's going to be ST depression, which you see right here. So those are standard changes when potassium is out of range. Now, in terms of treatment, like I said, when I worked in the emergency department, my first concern was putting them on cardiac telemetry. We got to look for any concerning arrhythmias. But additionally, we're going to hold medications that waste potassium, like those loop diuretics. We're going to hold digoxin. Now, wait a second. Digoxin isn't going to raise the potassium level. Why are we holding the digoxin? This is an important concept. Yes. Excellent. Yes. So proud you knew this one too. Basically, when potassium levels are low, they increase the risk for digoxin toxicity, which is dangerous. That can cause severe bradycardia and arrhythmias. So if potassium is low, hold the digoxin is a big rule. You're going to increase the dietary potassium. You might even give them some oral potassium supplements, but let me tell you guys, those are really not fun to take. They're hard on the tummy. So just make sure you take those with food. And then we're going to give IV potassium as well. And let me tell you guys, IV potassium is no joke. It's a high risk drug. And as a matter of fact, when you give potassium, you have to have two nurses signing off on it. It's that serious. And it's because, exactly, Shayna, you never ever give this as an IV push. You always give it slowly as a secondary piggyback line. Can anyone tell me what's going to happen if you just push potassium in really fast? What's going to happen to our client? Think about their heart again. Yeah. Yeah. It could literally cause their heart to stop beating all of a sudden. So you never push this. You always give it as a secondary line. But you guys were saying something else important. You also have to be careful about giving this IV because it's a vesicant. Ideally, we don't really want to give this in a peripheral line because exactly you can have what's called an extravasation where it leaks out of the vessel. And then you get something like that. You get this big ulcerated, burned wound in the peripheral vein, and it can cause some permanent tissue damage. So if we can help it, we should really try to give this on a central line. Remember, we also want to encourage potassium rich foods. And as you can see, there's a lot of them. This is going to be a hard list to memorize. So I'm just going to point out a few that show up, especially on the NCLEX. So, of course, bananas, that's a big one, but also oranges, avocados, and fish. Those are going to be the big ones that we see showing up on the NCLEX. So I would especially focus on memorizing those, but do, just generally be aware of some of the other options. And again, we can also give potassium supplements like K-lights, low K, but just remember they are really they're unpleasant. One of my family members actually had to go on, I think it was like 8 potassium supplements a day because they were taking a lot of diuretics due to kidney issues. And they developed the worst GI issues you can imagine, just horrible heartburn. So just warn the client, it tastes bad. It's hard on the tummy. So definitely take it with food. And again, guys, IV potassium, always on a pump, never IV push. Okay. Another quick pause. I want to highlight next our wonderful private tutoring team, which I do a little bit of when I have time. Jennifer does as well in the chat. You can see we have a lot of people who do private tutoring, but this is really nice because you can really tailor these sessions to whatever your need is. It's going to be $75 for the hour, which might sound like a lot, but you do get a lot of bang for your buck. The tutor can create a study plan for you. They can analyze, are you ready to test or not, and increase your chances of passing. They can review hard content. They can review question taking strategies. So again, you can just really tailor it to your needs. And I find that when students do at least one session of private tutoring, it really enhances their chances of passing just significantly. No, someone just had a good question. Hey, I test next week. Is it too late? Absolutely not. This is a prime time to check in, make sure you're really ready, and get those last minute testing tips. It helps. It really does. Yeah, you're welcome. So, of course, if we talk about low potassium, we got to talk about high potassium. What do you think can cause that? Burns. Yeah, I mentioned that before. That's a really good one to know. DKA is a good one. Too much intake. Spironolactone. Very good. Renal failure. Very good. I'm seeing a lot of good ones. I'm impressed by how many you guys are getting. ACE inhibitors. Very nice. Yeah. Yeah. You guys know your stuff. So yeah, with hyperkalemia, again, that's going to be a potassium over 5. So it's going to be elevated. And there's a couple different things that are going to cause this. First of all, remember, most of the potassium in your body actually lives inside your cells. So if it shifts from in to outside of the cells, you're going to have a lot of potassium. So we see that with burns and tissue damage, but also that diabetic ketoacidosis. Remember, when your body is in an acidic state, it's going to cause that potassium to leak out. And then on top of that, if you have DKA, you don't have enough insulin, so the potassium can't get back inside the cells. Of course, too much total potassium, if you're just eating too many potassium rich foods or supplements, or renal failure. If your kidneys aren't working, they can't filter out the excess potassium. And then you guys got all of these medications, ACE inhibitors and spironolactone, those potassium sparing diuretics. Those are actually going to increase potassium in the body. And we have the causes here. Machine is the mnemonic. Medications, acidosis, cellular destruction, hypoaldosteronism. Remember, aldosterone is supposed to push potassium out. If you don't have enough, you're going to have a lot of potassium, too much intake, and then nephrons like renal failure or excretion being impaired. So again, we got to look at the assessment and remember again, with potassium, it impacts nerves and muscles, especially the heart. So again, we're looking at those cardiac changes first. There's going to be impaired cardiac output. So we're going to see weak pulses, bradycardia, hypotension. But first thing we got to do, we got to put them on a monitor and we've got to look for those EKG changes. But we're going to see the muscle and nerve changes as well elsewhere in the body. We're going to see weakness and numbness, shallow respirations. Again, that diaphragm is impacted. We're actually going to see hyperactive bowel sounds. So you get cramping and diarrhea. And again, we have a nice little mnemonic here, murder. Too much potassium will murder my client, is how you want to think of it. Muscle cramps, urine abnormalities, respiratory distress because of the diaphragm, decreased cardiac contractility, EKG changes, and then reflexes are affected as well. Now, again, first thing you see that potassium's high, I'm going to put them on a monitor right away. And there are some things that are really going to show up a lot on the NCLEX here. You're going to see those tall peak T waves right there, and you're going to see that widened QRS right there. Those are the things they're most likely to test on. That being said, there's also going to be a widened flat P wave. But remember, no matter if potassium is high or low, there are 2 EKG changes that are always the same. There's always going to be that prolonged PR interval, and there's always going to be that depressed ST segment. So make sure you remember those as well. Now, in terms of treatment, you have to know first that what we do just really depends on the severity of the hyperkalemia and also the symptoms that the client's either having or not. So first of all, like I said, always we're going to monitor that cardiac rhythm first. And pretty quick after that, we better make sure that we discontinue any potassium supplements as well. So if we have IV potassium, PO potassium, we've got to stop that. And we're also going to restrict potassium in the diet, of course. Additionally, this is a big one. We're very quickly, if there are any EKG changes, we're also going to give IV calcium gluconate. That's usually the #1 treatment, but we can also give IV chloride as well because it protects the myocardium. It actually helps to prevent them from going into those fatal arrhythmias. Additionally, remember, potassium usually likes to live in the cells, so we can push it back in. We can do that with a combination of sugar water and insulin. Remember, potassium, it likes to grab onto that sugar, and then the insulin opens up the channel into the cells, so both sugar and potassium can get pushed back into the cells, basically. But just so you're aware, albuterol and bicarbonate, we don't use those very often, but those can also push potassium back into the cells. Additionally, we want to reduce total potassium. We can push it out of the body, and we can do that with the laxative K-oxalate that you guys were talking about earlier. We can use those diuretics like thiazide and loop diuretics. And this is the one, dialysis. This is the one that we don't do very often. But if you have someone with really severe hyperkalemia and they're showing really concerning signs like those EKG changes, we definitely could do dialysis as well. And we have a nice little treatment mnemonic again. Hyperkalemia made my client cry. They cried because they had hyperkalemia. It's maybe a better way to put it. But it's going to spell out the mnemonic cried. So we're going to give calcium IV to prevent those EKG changes. We're going to get rid of sources of potassium and increase excretion out of the body. We're going to enhance uptake into the cells, especially with D5W and insulin. And of course, last ditch effort. If things are going bad, the potassium's still high, we can always use dialysis if really needed. All right, let's wrap up with a couple of tricky questions again. Let's head back to Slido. All right, so this is a good one. It says the nurse is evaluating the client's lab results and notes that the potassium is 5.5. The nurse reviews the telemetry monitor and expects to see which of the following signs. And again, it's a select all that apply. So I couldn't make it an easy one for you. So there might be more than one answer here. Nice, Bernice. Shayna, you too. Good. All right, let's take a peek. Yes, most of you guys got this. I'm impressed how many. Of course, yeah, this is a high potassium. So we're going to see those widened QRS intervals and the tall peak T waves. Those are the two main features we're going to see. Okay, let's just do one more. All right. The nurse is reviewing client assignments for the shift and has each of the following clients. Which client is most at risk for hypokalemia? So which of these clients is going to have low potassium probably? Ooh, this is tricky. All right. I know I didn't give you much time. We only have 2 minutes left, so let's take a peek. Yes. 77% of you guys got this. Excellent, excellent job. Yeah, it's going to be the client with hyperemesis gravidarum. Remember, this is just a horrible condition. Basically, this is a condition in pregnancy that causes you to just vomit nonstop. You cannot stop vomiting. And of course, you can lose potassium through that vomit. On the other hand, all of these other things are actually going to cause potassium to go up. Renal failure, you can't excrete the potassium. Third degree burns, potassium's leaking out of the cells. And then diabetic ketoacidosis, again, potassium is leaking out of the cells there. Okay. that is it for our presentation. So we got through sodium, we got through potassium. Tell me in the chat or wherever you are, how do you guys feel about those electrolytes now? Hopefully a little bit better. Ooh, 5. I like hearing that. Better. Yeah. And I don't expect you guys to be experts. Definitely go back and review some of these concepts. Everyone still needs to go back and practice a couple times, right, to really understand a concept. But I thought you guys did great today. And I just want to remind you that no matter where you are in your Archer journey, we're here to support you. If you're pre-nursing, click here. We have a TEAS program. We have a wonderful nursing school companion for those of you who are in nursing and having trouble passing your exams on a certain subject. We, of course, have NCLEX prep for both PN and RNs. And we even have a new nurse practitioner program, which I'm really excited about as well. But again, I want to say thank you so much for joining. We really care about your journey with us and hope you learned a lot today. So thanks for coming out. I hope all of you have a wonderful rest of your day and take care. Thanks for listening. Thanks, guys.